Yes, welcome and thank you for joining today's webinar. The title of today is Getting It the Right First Time, Optimizing the Index TAVI for Durable Outcomes in Young and Intermediate or Low-Risk Patients. It's my privilege and honor to share the room with two extraordinary interventional cardiologists, with Professor Buckert from the University Hospital Ulm, Department of Cardiology, and with Dr. Arif Khokhar from Rigshospitalet in Copenhagen. So the today's learning objectives are to describe the role of the multidisciplinary heart team in the evaluation and treatment planning of intermediate and low-risk patients undergoing TAVI, to outline the key principles of lifetime management in intermediate and low-risk TAVI patients, and contrasts these with management strategies in high-risk populations, to understand how artificial intelligence-based tools can support clinical decision-making in patient selection, procedural planning, and long-term management of low and intermediate-risk TAVI patients. So again, a very warm welcome from me. My name is Alper Öner. I'm from Leverkusen, Germany. So I would like to hand over to you, dear Dominik, to start with the case presentation and then engage directly to a discussion. Maybe we do it in a different way, not in a lectural way, maybe in a more conversational way that we can, and you can also interrupt and ask your questions.
At any time. Thank you very much for the kind introduction. It's really a pleasure to be here and to spend the next hour with you guys in the room and the people in front of the screens. With this interesting topic we want to deal with, and we want to get our heads around, and to do so, as you already pointed out, we try to have a real deep dive conversation more than just a frontal lecture. But to start things first, I want to show you a small recap of the case you already could be familiar with. In advance of this webinar, this case was uploaded to the PCR platform, and after the recap, we want to dive into the actual treatment of this patient and, of course, the discussion coming along with it. So, to just summarize the most important features of this case, it's a 68-year-old woman who was referred to our Center for the Evaluation regarding aortic valve replacement in February 2026, so just a few months ago. The aortic valve stenosis was known for quite some time, but was getting worse, and her clinical presentation was getting worse either. So at the time point when we saw her, she was in a New York class 3, but with no signs of decompensation, normal general and nutritional status. She exhibited only a small, let's say, burden of comorbidities. The most important one was a transient ischemic attack without sequelae, but that was quite in the past. So these are the major findings coming from the basic evaluation. You see the ECG and the blood test result, pretty normal, let's say. And this is the echo assessment. You see the real good LV ejection fraction, concentric hypertrophy, but not too advanced. Overall preserved function, right-hearted and left-hearted. So what we saw at this point was high flow, high gradient, classic stenosis with a mean gradient of about 50 millimeters of mercury, no aortic valve insufficiency, and only physiological or grade 1 mitral and tricuspid valve insufficiency, normal pulmonary artery pressure. Coronary angiography was performed by the referral center, and I show you just the two short clips.
So Dominik,
yeah.
May I interrupt you here? Because you show us the coronary angiography, and maybe it's in my interest, but maybe in front of the displays, a lot of people maybe ask the same question. Is it mandatory in your institution that you perform a coronary angio in advance before doing TAVI procedures? Maybe the question to you and to you as well, Arif?
Yeah. I'd like to answer with this line. It's mandatory to know the coronary situation of the patient beforehand. You don't necessarily have to do the angio on your own. Referral centers is okay. In cases our referral centers haven't done the angiography, we will do it.
So in 100%,
yes.
Nearly 100% of cases
yeah.
you do, and in your center, Arif?
Yeah, I would say in our institution we've shifted towards more a CT-based assessment, and particularly if the proximal vessels are clear, then that's deemed sufficient for coronary anatomy. But if there is a patient who has predominantly chest pain in the symptomatology, previous PCI, lots of calcification, then they may proceed indeed for invasive.
So independently from low-risk or high-risk patients?
Yes, independent.
The decision is independently from low-risk or high-risk patients?
True. Okay. It's tailored to that patient.
Okay. Thank you.
Mm-hmm. So we move on with the case. As you already have seen, coronary artery disease could be ruled out. And so we come to the most important planning tool before aortic valve replacement. It's the CT evaluation. You see there's not too much calcification. It's a tricuspid anatomy, moderate to severe calcification, with a parameter-derived annulus of 24.5 millimeters, error-derived 24.3, so quite symmetric anatomy.
To be in the conversational style, you do not measure the Agatston score?
No, we don't.
Not routinely? So,
not routinely, yes.
You have a high, we see you are a classical aortic stenosis with not that maybe severe calcification, but you can measure it in the echocardiography. Do you use Agatston score measurements routinely?
No, Agatston's no, but we use the volume feature that's on the 3-Mensio planning platform to give an idea.
So it's not mandatory to have an Agatston score?
No, I think it's helpful in low flow, low gradient situation.
Okay.
This is where the guidelines actually recommend to look for calcification, to the extent of calcification. When talking to radiologists, this Agatston score thing is not that easy. So there is a lot of presumption going into it. So the generalizability of the different thresholds are not that well evidently supported as we think. But to look if there's calcification, and if, let's say, by eyeballing the extent of calcification is enough to deem an aortic stenosis as high grade, that's important in a low flow situation. Okay. That's my summary.
Yeah, I would maybe also add, we'll talk about the Agatston score from a diagnostic point of view, but from a planning point of view, there's a lot of value in getting a qualitative feel and actually scrolling through, because it's not just the number on the report that tells you whether this calcium, how it will behave when you implant your valve, where is the calcium, symmetrical, asymmetric, basal, leaflet tip. So I think there's a lot more value actually to be gained from just scrolling through and looking at that calcium itself.
So for me, it's important maybe at that point to point out that it's important for interventional cardiologists to do the measures by himself or herself, isn't it? So not only to look on the, as you said, not only to look on the, Agatston score, coronary heights, and whatever, you need to have a feeling about the CT scan. Yeah. Do you agree?
Yeah, I totally agree. And to be honest, nowadays, in a high-volume center, you need 30 minutes to perform a TAVI.
Yeah.
How much time do you need to plan one? It's about 1-to-1 ratio nowadays. Absolutely. And the time you spend while planning a case is so important for then performing it straightways without too much decisions you have to make during the procedure. And I think that directly results in safety for the patient.
It's absolutely crucial, and we have to point that out. Yeah. We are talking about lifetime management, we are talking about optimizing the index TAVI, and I really do believe that if you want to have an optimal result, you have to be in the case from the very beginning this means from the starting, the planning, and the doing the procedure.
Yeah, absolutely. I mean, time spent upfront planning just reduces that cognitive load when you're in the procedure. And as you said, will also reduce the time probably in the procedure because everything is planned out. Also complication planning, bailout strategies, everything can be thought of upfront.
Yeah,
absolutely. So thank you.
All right, let's move on with this case. You saw, that's the next slide anyway. Not only looking at the valvular anatomy, but also looking at the whole complex of LVOT, valvular anatomy, ascending aorta anatomy. In this case, we have a nice angle of 45 degrees, so pretty much
at which point would you say this is more horizontal aorta?
Yeah.
Which is nice for you and which is not nice for you, Arif? Would you recommend?
I would say we don't look at only the number now anymore. It's a couple of things. One is the angle of almost attack or the approach. So some aortas can be very horizontal, but you have a very long runway almost to the annulus. Others, they'll come down and then a very sharp sort of angulation. So I think it's, again, coming back to not looking at the number, but diving into the CT and looking at the shape itself.
Absolutely.
Yeah. And that's why I like nowadays. It took some years to go there, but nowadays I'd like to speak of the complex of the ascending aorta, valve, and subvalvular structure more than just looking at a tiny part of it. So next thing we assess coronary heights. I think it's pretty fine in this case, 40 millimeters on the left-hand side or LCA side. The RCA side, 18 millimeters. So that should not be that problem. And concerning femoral access or access sites, overall, we have to deal with a younger patient, not that high atherosclerotic burden. Pretty much no tortuosity, so this quite looks fine. The summary of the case, as I presented it to you on the web page, we have this 68-year-old woman, symptomatic aortic valve stenosis, high flow, high gradient, tricuspid valve anatomy, not hostile, pretty much standard. Coronary artery disease has been ruled out. We have no relevant comorbidities to the aortic valve replacement. And we have this strong patient preference for an interventional approach. Putting all these features into the scoring systems we can use, you see it's indeed a low-risk patient with a Euro score of 1.44 and SDS score of 1.5. So the questions that I have asked the community were like this. Would you advise the patient to undergo surgical valve replacement, contrary to her wishes, or comply with the patient's wishes and plan for a transfemoral aortic valve replacement? Second question is, when performing TAVI, which device or, let's say, which strategy would you apply? Based on the information that I have given you, and as you can read, to achieve optimal hemodynamics, but to avoid pacemaker and have in mind that this patient most probably will have a redo procedure.
Maybe you stop here before we go into the poll and look at the results. Arif, from your point of view, what would you advise to this patient? How would you treat this patient, and how would your heart team react when you go with this patient into the heart team and ask the question, TAVI or surgery? What would you?
Yeah, great question. I think this is a typical for most countries around the world, generally a surgical looking patient. We have to be very clear about that. The age is young, the STS score and things are low. So this patient would do well from surgery when we just look at the patient profile. When we look at the CT scan and the anatomy, the calcification patterns, and there's nothing really high risk or red flags, you've got good transfemoral access, so the patient would also do well from TAVI. Then it would be an open and an honest conversation with the patient to say that, look, we have these two strategies, this is what our guidelines say, and this is what the data shows. We don't have so much data when we get to younger than 70 years old. Durability at the moment we have with very first early generation devices up to 10 years. Now with partner 3, we're getting up to about 7 years. We don't have much more than that, and we would all probably agree this patient is looking at minimum 10 years life expectancy. So we don't have those answers yet to have that conversation. So I think it would be a very open, candid conversation with the patient and express, all aspects, because there's also an element of hospital recovery, length of stay, and all of those things. And then ultimately make the most informed decision.
And how would this transient ischemic neurological thing affect your decision with this patient? Is that something you are, you have concerns about that topic, that the patient had a TIA?
I think it would depend on what was the circumstances. Why did they have it? Was it embolic related? Was it a one-off? Was it carotid disease? And that would probably all be investigated in the workup of the patient. So I think it would be more depending on why they had the TIA. And I don't think it would change too much strategy of TAVI versus surgery.
But is it then more favorable for TAVI, or is it more for an aspect for surgery? What would you say?
Here, I would say, so TIA itself, I don't think would distinguish too much between the two. If, however, the situation was stroke with a dense residual hemiparesis, which may impair functional recovery and physiotherapy and recovery after surgery, then it switches the conversation a bit more towards TAVI. So like all things, I think it's not ever a binary decision, but in this particular case, if it's TIA, no residual neurological deficit, probably okay both ways.
And Dominik, how did you... or was there an effect of this situation for your decision? Or is it like, you just go to the STS score and see it is about 1.4 and this is a clearly low-risk patient? Or do we have to consider about that topic that there wasn't TIA?
Yeah, I pretty much want to highlight what Arif already said about this topic. So I think the TIA, when looked at alone, and this event happened several years before the actual situation, has not that really strong implication for the valve replacement that is now under observation or now under assessment. I think one aspect that could be added is how is the vessel situation? Was it an atherosclerotic event of the carotids? Then, if that would be the case, you have to have that in mind. But we ruled that out as well, even with the CT. So there actually was no sequelae left, and so we had it in mind, but we didn't pay too much attention and too much implication out of it.
But at the end, 68 years old, very low-risk patient, I would say the guidelines strongly recommend that we should go for surgery. How do you handle situations where patients' preferences conflict with the heart team recommendations or with the guideline recommendation? It's a topic about, reimbursement maybe, but also is patient preferences always the right thing we have to consider? How do you handle this situation? It's a psychological difficult situation as well. You are the physician, patient trusts you, and you have to explain what the options are. And the guidelines are actually in this case pro-surgery. Yeah,
and we were also. I can admit it. It's no admittance. It's just a clear fact, as you pointed out. So the heart team came together. We saw the features of the patient. We had the evaluation, and we said, it's a surgery candidate. And we went to her, and this was our first recommendation to undergo surgery. And then the conversation started, and we pointed out the different highlights of both approaches. in this particular case, it's really, really important to have in mind it's a young patient, for sure. That's a point for surgery, at least nowadays. But the anatomy allows you to perform TAVI with a good outcome. It's a whole different aspect or a whole different thing when this 68-year-old woman with bicuspid anatomy, with strong calcification, with a few hostile things for a TAVI approach, just wishes not to be operated on. Then the conversation has another drive and has another force towards what is the medically better outcome. Yeah. And this was not the case with her. So we said surgery is recommended first. But honestly, we think we can do a transfemoral aortic valve replacement with good result. And we explained, the open questions with her, and then came to our decision in consensus. And that's the most important factor, because in your team, when you fight in your team, everything goes worse. Yeah. Imagine you have the 68-year-old and the cardiologists have won the war, let's say, and perform TAVI and something goes wrong. And you need the help of your surgical colleagues to fix the situation. It's much better to have consensus up front than add fuel to the fire.
So Arif, you go with your colleague from cardiac surgery to the patient, that she has the option to discuss with you and the colleague from the cardiac surgery, at the end coming to a decision of all three, yes. I would say.
Yeah.
So it is mandatory that the patients have also the option to talk to the surgeon. Is that right?
Yeah, I think so. I mean, these are difficult scenarios because really, we know we could probably do a TAVI and get a good result, but the guidelines and most of the data is saying, okay, maybe this could be surgery. So in this case, you do everything you can for the patient. Yeah. And that's not only clear, open, honest communication, get the surgeons to speak to them, get somebody else to speak to them, and you really try to do your best from a communication point of view.
And what you said, to achieve a good result, for our topic today, is it enough to have a good result? Just a provocative question to you and to you as well, Arif. Is it enough for this patient to have a good result?
It depends on how you define good. Of course, it should be an excellent result. Okay. It should be an excellent result with both ways.
Best possible result.
Best possible result, for sure.
Okay.
I mean, I think the goalposts of what is a good result has shifted. Yeah. What it was when we were doing extreme high risk and high risk TAVI, what was a good result then was that your patient was alive.
Very good point.
And was discharged from hospital. Then we shifted towards, okay, we want to have less than moderate PVL, maybe no pacemaker, and okay, single-digit gradients. But now the goalposts are shifting. Now Absolutely. What was before okay and acceptable in the past is just only, let's say, that's a baseline. Yeah. And now we need other things that need to be optimized. So really, the goals are just shifting as we're going younger and younger.
Okay, perfect. So go ahead. I'm really keen to see the results of our poll.
Okay. So this is what the community has answered concerning the first question, and 2/3 would go with the patient's wishes and go for a transfemoral valve replacement. I think. Okay. That's
2/3 to 1/3, okay.
Yeah, that's interesting.
It's a discussion, so it's good to have a discussion, the same as we performed here.
Yeah, and
the second question was which prosthesis, okay?
Yeah, can go? I just jump back to raise awareness of the second question. So I ask, would you go for self-expanding in order to achieve optimal hemodynamics? Coronary artery access is not that important, and redo procedure may be of secondary importance
so
after
Dominik,
the initial design.
Stop here. I ask the question to me. I would say it depends on.
Yeah.
And your answer is?
I mean, this is a $1 million question, quite literally. I think here the most important thing is it depends on your experience.
Okay.
So in your center, in your hands which device will give you the most reliable, predictable, and optimal procedural outcome. And then that is the best device to use.
Yeah.
Then if there's complete equipoise in your own hands in the cath lab, then you can start to dive into, some advantages, pros and cons of one versus the other. But I think the first thing has to be that you will reliably get the best result you can.
So before we go to the results, I would mention one thing. Hello, everyone, and professors, greetings from Uganda, East Africa. So we have guys from East Africa, Uganda watching us. So go ahead, please.
Yeah. So the answer to the second question, also 2/3, 1/3.
Okay.
2/3 of the community would go with a balloon expandable prosthesis due to these aspects. Lower pacemaker rate, preserved coronary access, less complex redo procedure, and other third would go with a self-expanding prosthesis.
Is that true that you have a easier second procedure if you use a balloon expandable valve as an index valve? Is that a narrative which is true, or would you say it depends on the planning in advance, like?
I would say it depends on what you're planning to revalve your first valve with. So if your second valve is going to be also balloon expandable, then sure. But if your second valve is a self-expanding valve, then you in your mind said a balloon is easier, but now you're putting a self-expanding technology inside already something which has a bit of metal and fibrosis and calcium can be challenging. Versus if your second valve is a balloon expandable, then it's just you coming in. So I'm not so sure.
So how did you solve this case? I'm really, really, really excited to see that.
Yeah, and I'm happy to share the rest of the case with you. Our procedural plan is as follows. We obviously went with the patient's wishes to go for a TAVI. We performed it under conscious sedation with bifemoral access.
Stop here. Bifemoral access is not that common in these days. You use bifemoral access, and if I read the next sentences, I see, okay, now I understand you used a cerebral protection device by Boston. It is the Sentinel device. It's a device which comes from the radial access site, and it is a cerebral protection. So the question again, is the reason for using cerebral protection in this particular case the TIA, or is it something you are using routinely in your center?
Yeah, it's pretty much our institutional standard. There's a lot of discussion on this topic. Some evidence pro cerebral protection in avoidance of stroke, of disabling stroke. Other studies that were neutral and this effect couldn't be seen. I think there's discussion going on. In Ulm, in my center, we have a long history of using cerebral protection right from the beginning, and we're quite familiar with the system as well. And that is an important point that has to be mentioned. We have some agreements with companies in our hospital controlling to perform our TAVIs with the use of cerebral protection, but without losing too much money. So the reimbursement issue isn't there for us. And so we try to use one in just every case, unless there's some anatomy that's avoiding it. So this is our standard workup or our standard plan and setup. Nothing to do with the TIA.
Okay. The second question is here. You have balloon valvuloplasty using a 24 millimeter balloon. So when I remember your sizing chart, this is very close to the perimeter or to the diameter of the annulus. How do you handle this topic?
Yeah, we are nowadays quite aggressive in lesion preparation, let's say, of the original valve, especially for self-expanding platforms. So the lack of radial force coming with these platforms needs to be overcome, and the valve needs to be prepared well And our sizing, unless there is a very high grade of asymmetry, is annulus -1 or even 1:1.
Okay, great.
Depending on calcification.
The same in your experience, the same or?
Depending on the valve being implanted. So if it's self-expanding technology, then yes, perimeter derived -1 or 2, and then depends on the hostile calcifications.
And what do you mean with hostile calcification? In which position? In the valve position or in the LVOT position?
LVOT, annulus, or extreme asymmetrical calcification.
Okay. Yeah. And the last point maybe in your procedural plan is wire pacing.
Yes.
You routinely use wire pacing without
yeah.
Okay.
Yeah. In patients with a pre-existing AV block, we go for a right ventricular pacemaker lead because it's very common that they at least have some transient AV disturbances, and then everything gets quite hectic. But when we see an ECG like hers with no pre-existing AV block, then we go for wire pacing.
Okay, so great. Go ahead.
So just to get you an impression of the cerebral protection, we already talked about that. This was a little bit tricky thing because of a bovine anatomy. And you see that we've placed the cerebral protection in a way that is not IFU-like, so we directly probed the carotid artery on the left-hand side and then put the system in, which takes about 2 minutes all in all, so very quick step. And then the next step is a proper.
Yeah, I love that fluoro because, you know, as you can see here, if you do a proper pre-dilatation, you have this dog boning in the first few seconds of your balloon, and then you see really that you really properly pre-dilated this valve. It's great, yeah.
And what is also worth mentioning here, is this your cusp overlap view?
Yes, it is.
And so you've done the pre-dilatation in the cusp overlap view,
We
which
always
is often
do.
the minor axis, and you will see the effect of your pre-dil. If you do it, let's say, in an LAO view, you may not appreciate the same information or expansion. It may always look good, but you may not appreciate. I'm totally glad that you even recognized it from the numbers from the C arm. But it's true. It's the non-coronary isolation view. Let's say, and we always perform our pre-dilatation.
And what type of balloon do you use? Is this a true balloon, or is this an Osipka balloon, or what type of balloon?
Yeah, it's an Osipka. It's a wax 3, so,
okay.
So it's a semi-compliant balloon.
Yeah. Okay, now we see what happened. We see the valve. We see the markers.
For the first time, yeah.
But it looks like you're trying to rotate the valve here a little bit.
Yes, we do. So it's we went for a Navitor implantation. A bit Navitor, 27 millimeters according to the sizing of the valve. And what you see here, the valve is in the descending aorta, and it's an attempt to have some kind of passive alignment, commercial alignment, and this is depicted here just to have the overlay of the two outside markers in LAO view.
So maybe I do not want to interrupt you, but I have to mention one thing because I also did some proctoring for this type of valve. There's not an opportunity with this valve to do an active commissural alignment. This is just for clarifying, especially if you pass the aortic root. So this is an attempt to maybe avoid a totally misalignment of the valve, which is, in my opinion, very important. And active commissural alignment will be maybe possible in the future. There are new technologies coming up in this valve, and you will be able to do commissural alignment. Actually, doing commissural alignment with this valve is not really recommended and possible.
Yes.
Just to mention for the audience.
Yeah. Thank you for the clarification. you said everything that one has to say about this issue. Never build up tension with this device in the aortic or in the.
It's very flexible. You know, you then give energy into the valve, and you cannot control this energy, and this leads to issues and complications we want to avoid.
Yeah, definitely. So we then pass through the aortic arch, and on the left-hand side, you see a non-coronary cusp isolation view, and on the left-hand side, you see how the development starts, and you see how we pretty much IFU-like.
So you always start with cusp overlap?
Yes.
Okay. So you follow the recommendations, the best practice recommendations yet.
Yes.
You start in the isolation view, so the cusp overlap view, and you do the same?
Yes.
Or? Okay.
Same,
yeah. What you can observe here is that there was a little bit more movement towards the ventricle that I actually expected. So you see that while deploying the valve, there's a little bit of movement, and the valve is coming down. Nevertheless, we continued developing the valve until the point of assessment, which is shown here. This is an LAO view, and you can see that the valve is a little bit too deep.
Okay, I would say 5 millimeters, or what?
Perhaps 6.
6 millimeters. Okay.
A little bit too much.
Okay.
That we actually go for, because it was our first attempt, and perhaps you can agree on that. In many cases, you need to do one implantation to have the information in this specific anatomy.
The reaction of the
device
okay.
And the interaction between the device and the anatomy, to plan your second attempt a little bit more tailored to the situation.
So as we talked before or mentioned before, we are not happy with this result because it's not good, I would say. It's a mediocre result.
Yeah.
It's not good, and you try to achieve the best possible result for this patient. And my question would be, do you use routinely fast pacing during the release of the valve, or not routinely in the first attempt?
No, in the first attempt, almost never.
Okay.
In many cases, the valve expansion is smooth, and you have time, good hemodynamics, and you have time to manipulate the system a little bit so that the implantation height is perfect. In some cases where everything is quite unstable and you have a lot of tension coming from the ventricle, a fast-paced or rapid pacing maneuver can help to overcome this. But with the first attempt, I would go just straight, so like we've done here. But I would say most probably this would have led to an okay, acceptable result, but acceptable for a 68-year-old is not what we aim
not
for.
acceptable for 68 years.
Yeah, that's it. So we performed resheathing, which wasn't filmed. So we start with the second, or we continue with the second attempt. Even started a little bit higher and put more effort in controlling the height. Here at the NCC side, you see the wire is released, so the tension from the system is released. We have still a little bit of coming down of the valve, but it looked better than in first place. And so we moved on to the LCC side to check for height. Actually, still it's, I'd say, from an aesthetic point of view, a millimeter too low. But on the NCC side, it's perfectly like we would have wanted it from the IFU point of view and from a practical point of view. So we proceeded with deployment.
Slow deployment.
Slow deployment. We have
comes a little bit up on the left coronary side.
Yeah.
A little bit more, yes.
Yes. As I would have expected from the from the aspect that the valve had during implantation. So we have this self-centering tendency of the valve and a little bit of tilting, but everything well under controlled, wire pulled back, and so on.
What I like in this
just go one
fluoroscopy, if you go further, yes, that there is no push or any pulling maneuver or pushing maneuver on the wire. So it's absolutely relaxed, that you can control the whole valve to centralize it by itself, I would say. So do you always do this, or do you use push or pull tension to the wire to control this type of valve?
Very, 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 very rare. Okay. When I have the feeling that I need to have this tension in the wire to keep the valve in place, I always try to think again if everything was correct to that point. Yeah. So pre-dilatation was okay, valve size is okay, and so on. Just to go through the steps of planning. And when then I come to the point, everything was fine, but it's awkwardly difficult situation, I would rather go for an implantation under rapid pacing than to go for much manipulation on the wire.
On the wire, okay. Because the wire manipulation leads often to energy in the valve. You cannot control this energy, so whenever it's possible, do not manipulate too much with the wire. So this is a Safari wire. Yeah. Do you have experience with other wires to have more control, maybe?
Yeah, we tried to. We had a case series done in our institution with Landerquist, just to go for a very, very stiff system, to have intentionally more control, but this didn't work out at all because the stiffness of the wire didn't match with the relative low stiffness of the capsule of the system, and the only thing we produced was parallax. So it was even harder to have a controlled implantation, and we kind of rapidly went back to the Safari system, which is a good wire for the system.
So great. Move it.
So this is the final assessment.
Looks great, from my point of view. Looks great. No really PVL. I do not see PVL. Maybe transvalvular, little bit of transvalvular trace, maybe.
Trace, yeah.
The depth of the valve is pretty much good, I would say. Maybe intentionally a little bit deeper, I would say, because we are also talking about lifetime management, maybe yet or later on. But nowadays we have to talk about that topic as well. So even if you are a little bit deeper than we probably learned before 2 years or 3 years ago, you have no conduction system disturbances.
No.
So is it the thing that we are too deep with the valve, or that we do too much manipulation into this area of, conduction system, which we cannot really see in the CT scans? Nico Piazza showed me how to recognize this part, the membraneous septum. But to be honest, I performed a lot of CT scans and analyzed my cases by myself, but it's really difficult to see this part. How do you see that? Is it a manipulation thing, or too deep, or what do you think?
I think it's probably a combination of factors. I mean, simple factor is, yes, membranous septum probably is not the only answer. It probably plays an element. So there's probably a difference between 10 versus 1 millimeters in membranous septum. Then if you've got a very elderly patient, poor conduction fibers, and if you simply sometimes just with a Safari wire or even with a balloon cross through between that NCC, RCC commissure, you already can induce conduction disturbances. So I think it's contact, how many times you hit it, scratching it sometimes with a self-expanding platform, probably the membranous septum, the patient profile. I think it's probably just a mix of factors altogether.
So we will talk later on about artificial intelligence and tools which improves maybe also patients' outcomes. But before coming to the topic of artificial intelligence, you decided not to do a second recapture or resheath again.
Yes.
So the reason for this was your gut feeling and your, I would say, experience intelligence, because it is a form of intelligence and you have a gut feeling not to do something, maybe what you can do because it's possible to do a second attempt for resheathing. What was the reason why you didn't?
Yeah, after the first one with the deep implantation, I really thought this can be done better. The second time was better, perhaps 80% better.
Yeah.
And the least 20% for the 100% optimal implantation results are really, really hard to get. And then you have to decide, is it worth to do a third attempt with another 5%, and a fourth attempt with another 5% in best case? Or is it actually getting worse while manipulating too much? So I think with a resheathable platform, because it's a feature to have this resheathing option, one resheathing or two resheathing maneuvers are perfectly fine to optimize your results. Everything that's coming after that leads to more problem than it solves problems. And I really agree with you. Pacemaker rates with a self-expanding platform, at least in my experience, have very much to do with contact of the whole system with the conduction system, and not just the valve in its end position. And it's more important to try to avoid to have much metal below annular plane throughout the whole implantation process. And with a lot of resheathing maneuvers, you are at high risk that at some point you will lose that containment and the device will dive deep. So this is something I would always try to avoid. And then 80% is the new 100%, or 80% is even better than making it worse.
Yeah, you're absolutely right, because I did it a little bit provocatively earlier. We need a perfect result for this patient. And the definition of perfect means, in my opinion, no complications, early discharge, no pacemaker implantation, no PVL, great hemodynamics. So you mentioned that in your postoperative course. There's no complications, discharge on day 3, no pacemaker implantation, and no PVL with a gradient of 6. So great result. And I would say we are ready for durability and lifetime expectation for this patient. Yeah. Thank you for your case.
Thank you very much.
Great. So I would say, Arif, maybe because for the sake of time, we have not that much time left, but I would love to see your case and discuss a little bit about the artificial intelligence tools, and maybe a little bit blink in the future to see what we are expecting to do perfect implantations for durability, coronary access, and TAVI maybe as well.
Yeah, great. Thank you.
The stage is yours, Arif.
So now we're going to take a patient and think a little bit about these more longer-term things. The patient we have is a 73-year-old patient with some cardiovascular risk factors, as you can see, and importantly, has coronary artery disease and a previous stent to the LAD. Is referred with classical symptomatic severe aortic stenosis. And if we look at the overall profile and investigations, on the echo we have high grade in AS, preserved LV function. We have an ECG which does show us left bundle branch block. The coronary angiogram, which in this case was invasive, confirms patency of that LAD stent, but no further additional stenosis. And otherwise, the renal function is okay, BNP slightly elevated, and we have a low surgical risk patient. So this is what the workup and investigations tell us.
Let me ask you, if you go back a slide, the LBB, is that a consideration, or do you have any considerations regarding this topic that you have a LBB for pacemaker?
Yeah, generally,
at the end of the procedure?
Yeah, generally a left bundle branch block, especially at 130 milliseconds, probably wouldn't worry us too much. Okay. It may have an influence on valve choice, but in general, no. If it was right bundle branch block, then yes, big difference.
Okay.
Yeah.
And what is with the renal function? The renal function is not that impaired. Does renal function really play a role in durability of TAVI devices?
I think so, absolutely. So we do see increasingly patients who have, especially younger patients, who have chronic kidney disease, especially end-stage renal disease. They just have a much more activated system and high degrees of calcifications. You can often get earlier or premature degeneration of these TAVI prostheses, yeah.
Okay.
So if we look into the CT scan, which as we've already highlighted is crucially important, in this particular patient we have, as you can see, it's a tricuspid valve. So we go young, but we don't have a bicuspid here, it's tricuspid. Symmetrical calcification, which is severe trileaflet calcification.
It looks like a small annulus, isn't it?
Indeed, good spot. So if we look at the annulus itself, this would be termed classically by literature to be a small annulus. Perimeter 73, the area is less than 430. We do also like to look not just at the annulus, but also below and above. So sinus of Valsalva, and in particular the sinotubular junction.
Why is that important?
So particularly the sinotubular junction can help you anchoring in terms of, particularly when you're using a tall frame valve for your index implant, but it's probably one of the most important anatomical parameters or dimensions when you're thinking of redo TAVI. Both the diameter, but also the height of your STJ is very important when thinking about redo TAV feasibility.
Great aspect, and I absolutely do agree. And sometimes if I go proctoring to different hospitals, they sometimes forget to measure the sinotubular junction, not only in the diameter, but also in the height.
Yeah.
It is very important to measure it in the height as well.
Yeah. And then we've got the coronary heights, and I think this image is quite interesting because in itself, the numbers look okay, 13, 18, fine. But when you look at the geometry of that aortic root, you see you've got this sort of stovepipe, narrow, slightly effaced sinuses, which may be okay for this index implant, but we need to keep an eye out for that long-term perspective and redo to have feasibility. And iliofemoral axis was okay, nothing much to say here. So we're the heart team here today, you, the audience, also the heart team. This is what we have. Our patient's a 73-year-old. We have previous PCI, baseline left bundle branch block. Then we need to look at the anatomy. What do we have inside of the patient? It's a tricuspid valve. We need to have considerations of a small aortic annulus, a short STJ, but suitable for transfemoral axis. And then we now need to start to think of the longer-term issues or the lifetime issues, especially as we're starting to treat younger and younger patients. So here that involves hemodynamics. We know about small annuli patients, risk of prosthesis patient mismatch, so that's a consideration. We have baseline left bundle branch block, so long-term pacing is also not without its consequences.
So, may I interrupt? Gut feeling. What is the life expectation of this patient?
Tough question. I would say ballpark 8 to 10 years, probably.
Okay.
Yeah.
Okay. Would you agree?
I haven't seen it, but I would agree.
Okay.
10 years is what you have to plan with.
Yeah.
Okay.
Then,
so if we are lucky, we do not need a second valve, but durability of 10 years, maybe, yes, but it can happen that you need a second valve in 6, 7 years.
exactly, yeah.
Okay.
Yeah. And that's why we then need to think about coronary access and then specifically redo TAVI. So these are all the considerations we need to take into account, not only TAVI versus surgery, which we've already discussed, but also TAVI, which valve type, and then how you would implant that TAVI valve and how you would perform that procedure. All of these things need to be taken into consideration. So we chose as a sort of standard conventional procedure for us, local anesthesia, nurse-led sedation, LV pacing, pre-dilatation here with a 22mm balloon, and chose a self-expandable Navitor 27mm.
So stop here, because there's something highlighted there, and I do not know why. You wrote there, target 5mm of depth. Where does it come from that you choose 5mm of depth for this case?
Yeah. So this is basically keeping in mind the longer term aspects. So I'm going to show you now, these are some computer simulation modeling. This is using the concept of digital twin modeling. You take the patient's anatomy. In that anatomy, you implant your index valve that you've chosen. You can simulate 2 different implantation depths of that index valve, and then go forward and do your redo TAV procedure. The results are, on the left-hand side, if we went with a 3mm implantation depth, you have a high chance of covering that left main stem or the left ostium after redo TAVI. If you simply lower to 5mm depth, your chances of covering that left main are much lower. You have a less overlap of that left main. So what we get is that we can choose at the time of the index valve 3 different implant depths, 3 millimeters, 5 millimeters, 7. 7 is probably going to be too low and give us a risk of conduction disturbances. 3 has a risk of covering our left main if we were to consider redo TAVI. So we thought that a little bit the sweet spot for this particular patient would be to go with a 5 millimeter depth implant.
So, this is extraordinary and a perfect solution, because you are planning not only the first index valve, you are also planning the second valve in advance to be prepared for that day if you need the second one.
Absolutely, yeah. Keeping the options open for the future.
Okay, and which tool was it which you used for this planning?
So this planning was based on FIOP software and computer simulation.
Okay.
So then this is the procedure. I'll just run through this quickly in the sake of time, but we pre-dilated with a 22 millimeter true balloon. A 27 millimeter Navitor prosthesis was implanted, and the final result that we achieved was no paravalvular leak, target depth of 5 millimeters, and single low-digit gradients.
So maybe two questions at that point. The first one is you choose a 27 millimeter Navitor because from the measurements you would have go also to a smaller one.
Yeah.
The first question is, why did you choose the 27 millimeter Navitor? And the second one is, we only have one projection for the final result. So I would like to see a second projection.
Okay, I'll answer your second in a second. The first question, indeed, this could have been maybe 25, 27, but the STJ was 27 to 28 millimeters.
So therefore it is very important to have the measurements, yeah.
Absolutely, yeah. Now, coming back to your second question, indeed. So frame expansion, we've understood, is such an important feature now for not only mid, but also longer term outcomes. We have randomized data telling us that if you have under expansion, you do have adverse clinical outcomes. So you can simply use fluoroscopy to go through orthogonal projections to see your frame and see if you're under expanded. We in Copenhagen have started using intravascular imaging and putting these vascular IVUS catheters to try to see what information we can get. And we can certainly understand a little bit about valve size, the geometry. Do we have under expansion, which allows you in vivo to respond and then to perform a post-dilatation, to maybe choose a slightly bigger post-dilatation balloon. But certainly a lot more information can also be gained purely by fluoroscopy.
A very, very important aspect which you mentioned, I would like to ask Dominik. Dominik, post-dilatation. Mm-hmm. Is that a topic which is important for you? Do you perform routinely post-dilatation, or do you have concerns about post-dilatation in this valve?
It's a really big thing that needs to be discussed. We do not perform routine post-dilatation because of concerns towards valve durability and harm, tear stress.
Leaflet damage.
That is done to the leaflets. So I think you can't say don't ever use post-dilatation. You need to have good reasons for post-dilatation, and then you have to perform it well and controlled, that you achieve the goal you want to achieve. So it's an individual assessment and individual decision, but there is some homework to do, I think, for the community, in which device, for which reason post-dilatation should be performed.
Yeah. Thank you. Sorry for interrupting, but what do you see? You do this IVUS measurements, I think, for research purposes. Yeah. I think it's a really good attempt, but it's not in the routine of TAVR. So you would also recommend to do a second projection always to decide to do a post-dilatation, yes or not?
So we routinely will always take 2 projections,
okay,
but that's only to look for frame expansion.
Yeah.
Then your post-dilatation decision is gradients, leak, frame expansion, and then also safety.
Okay, perfect.
So coming back to this patient, this is what the pre-CT simulation suggested. If we actually look and we went and performed a post-CT of this exact patient, you can see we achieved that 5 millimeter implantation depth. If we were to choose a short frame valve to revalve this patient, we would be below the neoskirt plane of this specific patient. So here we were able to achieve that optimized index implant, but still keeping an eye to the future and preserving the long-term outcomes. And that's where I would probably summarize and say that when we're treating these younger patients, it's important to consider not only the clinical profile, but also that phenotype that you have inside of the patient. We have to absolutely optimize that index implantation and also expansion, but then also keeping an eye for the longer-term outcomes, as we've done in this case. Thank you.
Great case presentation. We are on time, perfectly. And I have to say to you both, I really, really enjoyed it to listen to your knowledge sharing, I would say. It was my great privilege and honor to be with you here in this room and to learn from you guys. You are very, very experienced, and I'm eager to hear from the future from you, and maybe we will be invited in 5 years again to see the 5 years results of your both patients. Yeah. So I would say thank you very much for being with us, also online for being with us, and we keep going, developing the field of TAVI, and I really enjoyed it with you. Thank you for being here.
Thank you.
Thank you very much.